What to do if I'm having bleeding on menopausal hormone therapy? Well, the good news is that only happens to about 5% of patients who start on hormone therapy. Bad news is 5% is still a lot of people, so we want to address it. And the most important thing I want to tell you is if you start bleeding in the first few months of starting on hormones, don't worry. It's fine. It's nothing to worry about. It's a big fat annoyance, really, really inconvenient, but very, very unlikely that anything's wrong. So if estradiol and progesterone are absolutely perfectly balanced in our system in a menopausal hormone therapy protocol, we're not going to bleed at all. And that's why most patients don't bleed. We're taking hormones continuously. There's no up and down, so there's nothing to trigger us to bleed, and we won't bleed. Now, in 5% of patients, for whatever reason, if they're prescribed the perfect dose by the most careful provider, this happens in our practice and all practices, a small percentage of patients are going to have more of that estrogen effect at the level of the uterus. So they're going to grow some lining, and for reasons that are just because humans are all different, they're going to experience less of that progesterone effect, so there won't be that balancing effect on the uterine lining, and we'll see more growth than the opposite. Now, in that patient, they're going to grow some lining, which will eventually come out. So if we've got uterine lining, it will come out. So if we start on hormone therapy and the estrogen causes some lining to grow, at some point, and it's usually a month or 2 or 3 months into the treatment, typically we start spotting. It's not usually like a full period. It's more often just this annoying bleeding a little bit at a time, and it can go on and on and on, which is super annoying and very scary. Remember what I told you in the beginning, it's extremely unlikely to be uterine cancer or precancer or anything like that. It's almost always just a function of the uterus responding to these new hormones that we've seen all of our life, but new in the context of, in no way are we saying that that's okay. We want that to go away. So how do we work with a patient who presents this way? Let's say you came in, you were menopausal, you had essentially no estrogen or progesterone. We replace them appropriately. Now it's 2 months later and you've been spotting for 2 weeks. Well, the first thing I'm going to do is talk to the patient and reassure her. Say, hey, don't panic. I know you've been on Google and you're worried. Everything's going to be fine. That's number one. Number two is we need to get it to stop. So how do we do that? Well, we're recognizing that the patient's getting, in effect, too much estrogen and not enough progesterone at the level of the uterus. And that's a very simple way of saying things. The first thing to do is to address the progesterone. So simple questions like, are you taking it? It doesn't work unless you put it in your mouth. So we give progesterone in oral form because it is not absorbed well through the skin. So if that patient was using a progesterone cream and she had not taken my advice the first time, I would remind her this is exactly why we don't want to use progesterone cream. We don't get enough progesterone in the cream to prevent the uterus from growing lining and ultimately prevent uterine cancer. So taking it by mouth. All right, are you taking it every day? Are you taking it with food? Because micronized progesterone is in an oil base. It absorbs better with food. It does not absorb well on an empty stomach. Now, taking it at bedtime is important because it makes you sleepy. So for most patients, you don't have to take it with dinner, but if you've gone more than 2 hours without eating, it's not going to be absorbed as well. So this is quite common these days. Many people are eating their last meal 3 or 4 hours before bedtime because it's great for their blood sugar. So we'll look at those kind of things and just ask the patient to take it a little earlier, or maybe have it with a little milk or something, just something that will help it to absorb. So are you taking it, number one? Are you taking it at the right time? And that is within 2 hours of food. And if you're doing both of those things already, we can increase the dose. So progesterone, we had buckets of it when we were pregnant. It's a happy, healthy hormone. It's fine to take a lot of progesterone. The only side effect from doing that is it can make you really sleepy. So we're balancing that wonderful side effect because it helps with insomnia. You know, we don't want you to be too sleepy. So some patients need 200 milligrams and they get the same amount in their uterus as a different patient who takes 100 milligrams. So just to say, either dose is fine. We give you as much as you need. So we would make sure you're taking it, make sure you're taking it at the right time within 2 hours of food, and then make sure you're taking enough. So we would give you some more if you're still bleeding. Now, in the vast majority of patients, that will cause the bleeding to stop within 2 weeks. Problem solved. Now, if that doesn't work, decreasing the estrogen might be something to consider, but you get the idea. We're working with that balance to get it exactly right for you. Now, we wouldn't want you to have hot flashes, night sweats, and other symptoms as a result of decreasing the estrogen. So that's why you need a provider who really knows how to make this very personalized for you, recognizing that everybody's different. All right, so now let's just assume we got the bleeding to stop. Problem solved. If we don't get it to stop, and I would wait a couple of weeks, then we want to go a little further and do some investigation. First step is to do an ultrasound. A small probe is put inside the vagina, and it can actually measure how much lining you have grown. Now, the thickness should be less than 5 millimeters. If it's less than 5 millimeters, we pretty much know you don't have uterine cancer, though we've just kind of taken that off the list of things to worry about. On the other hand, if it's greater than 5 millimeters, by no means does it mean you have uterine cancer. It just means that we need to do a little more evaluation. Most likely it's benign uterine lining that's just growing because you're very sensitive to estrogen, or it could be something else like a little benign polyp, a little benign fibroid. There's a lot of other things it could be before your mind darts immediately to cancer. But whatever it is, we want to get it to stop. All right, so if it's less than 5 millimeters, we know everything's fine and we're comfortable just to wait a little bit longer and work with balancing the hormones to see if we can get it to stop. If it's more than 5 millimeters or 5 or more, we would offer the patient to actually get a little sample of tissue and make sure that it's benign, again, to put her mind at rest. A tiny little catheter is put inside the uterine cavity while you're in the office, and we wiggle it around just to dislodge whatever lining's there, and then it's sucked up into the little tiny catheter, and we have a small specimen that we can send to the pathologist. They're going to come back and tell us it's benign, and then we can all sleep at night. Now, remember in that scenario, there was more than 5 millimeters of lining there. We didn't remove it all with the biopsy. We just got a tiny little piece. So the problem is still there. In other words, you're still bleeding, but we've ruled out cancer, which is great. So the next step is, again, to get it to stop. If you're still bleeding and we've tried all the other things, we would next put a little camera in the uterine cavity. And then we can see what's going on. Is it a polyp? Is it just thick lining? Is there anything else that looks suspicious? And then whatever it is can be removed at the same time while you're undergoing that procedure. Again, at the end of that, then the problem, at least in the short term, is solved. Now, remember, whatever caused it to grow could come back if we haven't addressed the root cause. But for now, we're starting again with a clean slate. And for that particular patient, let's just say everything comes back as normal and benign. It was just related to the hormones. We would start on a little bit more progesterone, maybe a little less estrogen, depending on what her levels were. Make sure she's taking it at the right time. All of those things. Now, there's a very, very small group of patients who continue bleeding after we've done all of those things. Now, that's a patient that we might consider a few really unusual things that we don't offer to everybody. But one of the easiest is that could be a really good candidate for having a progestin-containing IUD, intrauterine device. So IUDs, of course, are used for pregnancy prevention, but the ones that are coated in progestin, which is a synthetic type of progesterone, do wonders for preventing the uterine lining from growing. So in patients who are using it for birth control, they often are thrilled that their period stops or becomes very, very light. But in menopausal patients, not only does it provide protection to the uterus, but it makes sure we don't bleed. So that could be an option for a certain patient. Very rarely would we ever tell a patient not to take hormone therapy because of this. So the reason that we don't want to tell you not to take it is because there are so many health benefits. So it's really important that we continue working on this until it's gone.